Dr. Yin, we're going to invite Dr. Nope, Dr. Yin, I think, right? Yeah, Dr. Yin's talk. So Dr. Yin is a surgery resident at WashU St. Louis. Sorry for the confusion.
Good afternoon, everyone. My name is Kang Hua Yin. I go by Kevin. I'm a general surgery resident at Washington University in St. Louis. But this work is a work that I did with Dr. Malas in UCSD about like 2 years ago, before I went to the residency. It's very nice to see my colleagues here, and also very nice to see the team here as well. By the way, I don't have any disclosures. I wish I had, but. Anemia is a global health problem that affecting millions of people worldwide. According to the World Health Organization, hemoglobin less than 13 gram per deciliters for men and less than 12 gram per deciliters for non-pregnant women are defined as anemia. And there's there's many studies have been shown that preoperative anemia is an important and independent risk factors for mortality and morbidity among a variety of major vascular procedures, including carotid endarterectomy, CAS, and EVAR for intact AAA, and also for the hemodialysis vascular access procedures, etc. However, there is limited data available regarding the association between the preoperative anemia and the TIVA outcomes. Before this study published, there were only like 2 or 3 single-center studies looking at only the patient who have type B aortic dissection. Therefore, the goal of this study is try to understand or even uncover the association between the anemia and the TIVA outcome. So we used the VQLI data from 2011 to 2019 because this study was done about 2 years ago. And we included all the TIVA cases for aortic dissection and aneurysm and penetrating aortic ulcer. We did exclude like patient who had treated aorta distal to zone 5 because we tried to avoid TAAA case. We also excluded patient who had a ruptured aneurysm, traumatic dissection, and who underwent emergent repair. More importantly, we exclude patient who had a polycythemia and those who received transfusion more than 4 units intraoperatively or postoperatively, because we believe that those patients their anemia is more or less likely due to the blood loss anemia. So we ended up included about 3,400 patients. We divide them into 2 groups. One is the normal or mild anemia group. The other one is moderate or severe anemia group, which the latter one is composed of about 950 patients. So for the sake of time, I skipped the baseline characteristic table, but I can tell you guys it's not very surprisingly, those ones who had moderate or severe anemia had a relatively older and they have a higher burden of comorbidities. And in terms of the outcome here, we can see that the moderate and severe anemia group had a significantly higher 30-day mortality, and also in terms of any type of in-hospital complications, those ones who had moderate or severe anemia, they are significantly higher than their counterparts. I want to draw attention to their 30-day mortality because there is about 4% in the moderate or severe anemia, which is almost doubles the normal or mild anemia group. And we know that the 2 groups have different baselines, so we adjust for, we did a multivariable logistic regression because at that time I don't know machine learning that much, so I will try in next time. But we only did a multivariable logistic regression. I did include quite a lot of the comorbidities, and sorry, not only the comorbidities, but also the demographic and the clinical and the procedure factors. And after adjusting about like 30 factors, we still find that moderate and severe anemia actually is associated with a 2.4 associated with a odds ratio of 2.4 for the 30-day mortality, 2.35 for the stroke, and 1.6 for the in-hospital, any type of in-hospital complications. And on the other hand, is actually those one who had moderate or severe anemia, they have a less chance of being discharged to home. Some of them will go to SNF, and some of them actually will be staying in the hospital for quite a long time and end up dying in the hospital. And we're also looking at the 1-year survival between these two groups. And not surprisingly, we find that those one who had a moderate or severe anemia actually had a significantly worse 1-year survival compared to their counterparts. Similarly, we did a multivariable Cox proportional hazard regression, and we find that the moderate and severe anemia is associated with an adjusted hazard ratio of 1.8%, suggesting, 1.8 suggesting that this group has about a higher, a 81% increased risk of being dead in their, die in their within 1 year after surgery. So in conclusion, moderate and severe anemia is associated with a higher risk of 30-day mortality, post-op complication, and 1-year mortality. This is an important risk factors for TIVA outcome and should be evaluated preoperatively and in the context of other comorbidities. And I think, although our data doesn't fully support the third conclusion, but I think that's a reasonable kind of speculation is that patients with moderate and severe anemia may benefit from being treated, being medically optimized to mitigate the occurrence of adverse outcomes. Thank you very much.
Really enjoyed this talk, and it really is provocative, but I have a couple of questions. Were all of these electively scheduled TVAR procedures?
Not really. I think about 80% are elective cases and 20% are kind of emergent cases. Urgent case, but we did exclude those one who underwent emergent repair.
Do you know if the breakdown of anemia was worse in the emergent cases versus the elective cases?
We actually adjust this emergency as a, in our multivariable logistic and Cox regression. So I think it has been like, taken into account.
Yeah, so even if they were emergent, it didn't factor in that anemia was still more severe. I mean, in my own mind, when we have patients come through the emergency room, they get like 2 liters of fluid in the ER. So I'm wondering if there's a delusional component in the patients who are coming in as emergency room patients versus patients who are scheduled as elective outpatients.
Well, sorry, can you repeat your question?
Yeah, so a patient who comes in who's having some kind of emergent procedure or urgent procedure sometimes gets fluid hydration and resuscitation compared to the outpatient scheduled patient. So there could be a delusional factor in the patients who are brought in and treated as a more emergent type patient or come in and get IV hydration in the hospital pre-procedure compared to the patients who come in same-day surgery for a TVAR.
Yeah, well, I don't think the VQI can answer this question, right. The current data, because in terms of urgency, VQI only classify as emergent versus urgent versus elective. And we did exclude urgent. I'm not sure how to answer your question.
No, I don't know if there's an answer. From my mind, there's a lot of delusional potential when people start getting hydrated in the hospital. So anyway, but I'd like to...
Yes, I agree with that, actually. But I thank you so much for this point. I didn't think of that. Yeah.
Thank you. One last point, I guess, would be, you recommended that we think about pre-optimization in these patients. I guess, do you have data to support that we can move the needle on these patients? That, the patients that are preoperatively anemic, is that just a marker of more severe disease in general, or is it that the anemia itself is the problem? It's probably a combination of both, to be honest with you, right?
Well, I totally agree with this point. It's like anemia could be just the mediator of those, or just a presentation of a more chronic disease process. Can be any type of chronic disease. And actually, I think a more kind of a further work down the road should be doing we call it a mediation analysis, try to understand whether anemia is a true try to understand the causal relationship between the anemia and the outcomes. I also suspect that anemia is both a confounder and a mediator. So this is definitely a very good point. Yeah.
Thank you. Thank you.